And you're on.
Okay, we'll go ahead and start. Welcome, everybody. We are having others continuously joining us, but we thought we'd kick off at the top of the hour. My name is Sue Sheridan, and I'm a co-founder of Patients for Patient Safety US. It is a chapter under WHO's Patient for Patient Safety Global Network. Today, we're here to talk about Project Pivot. That stands for Patients Involved in Developing Outcomes Together. I want to share that this is truly a work in progress, and the start date of Project Pivot is not until May of 2024. So we are building this unique project with all of you and many of our partners and collaborators and patient organizations. And so what Project Pivot is doing is we are really responding to the both national and international calls to action to improve patient safety, diagnostic excellence, and the experiences in equity and improving bias and discrimination. And the way that we want to do this is the call to action is for us to really consider redesigning many of the measures that we use to understand patient safety and discrimination and diagnostic excellence. And we at PFPS US identify that there is a significant opportunity to bring in the patient voice, not only look at administrative data, not only looking at outcomes and research that are very traditional, but patient reported experience and outcomes that really have been missing in the past. And we're going to talk more about that. But again, welcome. We're calling it Project Pivot because we are kind of flipping the model upside down. And we are starting with the patients and patient community in terms of identifying outcomes and experiences that really matter to us. And these are the experiences and outcomes that we want to share via a variety of instruments, patient experience measurements, surveys, and other tools. We can go to the next slide. So I first want to start by thanking our funders. We've had some very generous donations and grants from the Jewish Healthcare Foundation, the Gordon Betty Moore Foundation, and the John A. Hartford Foundation. We are pursuing additional grants. We have a letter of intent into PCORI and outreach to other potential funders as well. And the funding will determine the scope of this project. The heartbeat of this project will be the patients, patient organizations, patient advocates, the patient networks that we want to bring in as leaders in this project. So thank you to all the funders. You can go to the next slide. So Armando, I'm just going to keep going unless you jump in here wanting to do some housekeeping. But in the chat box, we had several people from other countries sign up for this, and we know that we have people from all over the United States. So in the chat box, if you want to introduce yourself and share where you're from, and please don't hesitate to, and I encourage you to post your questions in the chat box. We have some of our leaders moderating the chat box so we can address the questions at the end. There is going to be a recording of the webinar as well as the slides that will be posted on the PFPS US website that you can see right here on the screen. If you're interested in joining PFPS US as a champion, and we're going to talk about what is a champion a little bit, a strategic partner, or if you want to join, collaborate with Project Pivot, here are ways for you to reach out through our website so we can connect. And I have to share, we are so grateful for your enthusiasm and for your input. We've got a lot of input from many of you already online on helping shape this, and we will continue to shape this and make sure this is a project where we have a lot of input. Next slide, please. So the agenda today, just very quickly, we're going to talk about the Project Pivot leadership team and our champions. Dr. Neelam Dhingra from WHO is going to give us a welcome and the call to action from WHO. I'm going to talk about the PCAS and the report that talks about the gaps in patient-reported measures. We're going to cover some terminology. Sue Schrant's going to do a bit of a tutorial, because I know that we have a lot of champions and others that might be new to some of this terminology. So we want to cover some terminology. We're going to talk about how Project Pivot intends to fill this measurement gap that's been identified by both WHO and the Presidential Council of Advisors of Science and Technology. We're going to talk about building the Project Pivot initiative with you and the activities that we're proposing. We're going to talk about the outputs, dissemination, and implementation, and the value proposition of this, the so what of this project. And then we'll have a discussion. And we really hope to have a robust discussion, because I feel like it's all of us creating this project. Next slide, please. So I just want to introduce you a little bit about Patients for Patient Safety that we started in June of 2021. You know, really, the core founders, the co-founders of PFPS really identified that patient safety was falling off the radar in the United States. We were seeing it falling out of strategies, out of speeches. So while we saw patient safety kind of falling off the radar in the United States, we saw the WHO ramping up in patient safety. And Neelam is going to talk about that from WHO. So we decided to form under the WHO's umbrella of Patient for Patient Safety Global Network, and with our mission being to implement the Global Patient Safety Action Plan. Specifically, I mean, there's many elements of it that we want to implement, specifically looking at patient and family engagement to really elevate the voice of the patients and families and communities in the United States to really drive patient safety. Here you can see, I think we have 2 slides of champions that, you know, we started with 10 in 2021, and I think we're now up to around 70. Every one of them have gone through an orientation that it orients them to WHO and what we're doing. Can we go back?
Yeah.
Yep. There we go. So Patient for Patient Safety US is doing quite a bit in several levels. Please visit our website if you want to know more about us. Our team leadership is Beth Daly Ullum for this project. Carol Hemmelgarn, Armando Nahum, who you just heard, Marty Hatley, myself, and Sue Schrant, that you're going to see in a few slides. Next slide, please. So it's my pleasure and honor to introduce Dr. Neelam Dhingra. She is the unit head of WHO's Patient Safety Flagship. She has been she really is a legendary leader at WHO, and she has been the driving force behind the Global Patient Safety Action Plan that we've been talking about. It is a plan that is one of the most comprehensive patient safety plans I've ever seen, and it just gives us so much promise to see the WHO so dedicated to patient safety. Neelam, I'd like to welcome you to the webinar, and Neelam just can give us a little overview of the Global Patient Safety Action Plan, and actually the call to action that's embedded in that about creating mechanisms for patient reported experiences. Neelam?
Thank you so much, Sue. Really appreciate your kind words, and thank you so much for giving me this opportunity to join all of you today. And I get inspiration from all of you, deep inspiration for my work. I welcome all those participating today for this extremely important webinar on behalf of the Patient Safety Flagship, a decade of patient safety, 2021 to 2030. And I also want to commend the entire leadership team of PFPS US for its pioneering work, as well as for strategizing and prioritizing designing of tools that measure patient experiences and outcomes. As Sue mentioned, this is truly aligned with the action which have been recommended in the landmark WHO Global Patient Safety Action Plan, which is a roadmap for concrete actions on patient safety for a period of from 2021 to 2030. And it has a mandatory reporting requirement to the World Health Assembly as well. So measurement of patient safety improvement is embedded as part of this action plan. And as Sue mentioned, and the picture you see on your screen of the Global Patient Safety Action Plan towards eliminating avoidable harm in healthcare, patient and family engagement is one of the key strategic objectives of this action plan. This also identifies the guiding principles as well as several important strategies which are truly linked with the patient experience, patient participation, as the foundation for any patient safety program which is developed around the world. So the strategic objective on patient and family engagement in this action plan elaborates 5 strategies. And I truly believe that under the leadership of the team of PFPS US, all these 5 strategies are very effectively implemented across the world and also globally and also within the US as well. And these 5 strategies primarily relate to co-development of policies and designing the program together with patients and families, building the capacity of patient advocates, learning and consulting with patients and building through their experience. So the entire scope of work of patient-reported experience measures as well as outcome measures sits in the learning and consulting with patients and families while we are developing the patient safety programs around the world. And also would like to emphasize the need for patient education and training, as well as incident disclosure. So these are the 5 strategies which are covered under the strategic objective of patient-family engagement. And as you are aware, the World Patient Safety Day this year was dedicated to engaging patients for patient safety, with the slogan of elevating the voice of patients for patient safety in particular. And I truly believe that several countries around the world, inspired from PFPS US, have now established several national chapters of patients for patient safety around the world. The survey we collected, the survey we rolled out, and the responses we got from 110 countries, extremely inspiring and encouraging that more and more countries are establishing PFPS to provide a platform for patient voice and for them to engage with the healthcare system, and not only for their own care and own safety, but also for developing the system, redesigning the system, and for the safety of the entire system. Particular actions, as Sue mentioned, is we are asking governments as part of this strategic objective, particularly the strategy on learning and consulting of patients and families, is to establish and create mechanisms and strengthen platforms where patients can actually report on the outcomes as well as their experience. So whether it improves the quality of life, whether they are getting free from symptoms and the better treatment, or they're satisfied as part of their experience, and whether they feel that safe in the healthcare system. So these measures are really, really important, and they provide the foundation for any patient safety program. And I'm very confident that this pivot project will actually guide countries around the world to develop systems for patient-reported outcome measures as well as experiences, and collect information utilizing these measures, which can then lead to resilient and sustainable patient safety programs. Very inspiring year for me, particularly with the countries around the world observing World Patient Safety Day, providing huge platform for elevating the voice of patients. More than 155 countries have shared the results with us that they have observed the day, and they are creating new initiatives and mechanisms to provide patient voice in healthcare. So these actions, which are part of this action plan, are not only for governments, but also for healthcare facilities, for partners, as well as for WHO. And I truly believe that working together with leadership of a team of PFPS and experts around the world and patient experts from around the world, we can really go in a very strong way in eliminating avoidable harm in healthcare. So thank you, Sue, for this opportunity for me to connect with all of you. And I'm really grateful, and all the very best. Over to you.
Thank you, Neelam, so much. And thank you for joining us today. We know you have to run to do other things around the world. So we really appreciate your time and your commitment to this.
Thank you.
Thank you. Okay, Armando, we can go to the next slide. So Neelam just shared with you the call to action for the WHO, the global call to action for WHO, to really learn from the experiences and outcomes of patients regarding safety. And that includes diagnostic safety, and as well as, eliminating discrimination. So that was the global call to action. Well, here in the United States, we also have another call to action. And that was from a call to action by the President's Council of Advisors on Science and Technology, known as PCAST. A public report came out in September. I believe it was September 7th. I'm sorry I didn't give the website here, but you can just Google PCAST and report to the president, transformational effort on patient safety. It was about a 1.5 year long effort by a working group that I had the privilege of participating on, and other patient safety leaders, where we got to really focus on very direct recommendations to the president for him to implement in the government agencies related to healthcare. And so one that you can see here that was a call to action in this report was that the president should direct our Secretary of Health and Human Services to require AHRQ to develop and validate new questions focused on racial ethnic bias and patient safety in the HCAHPS tool. And we're going to talk a little bit about what is HCAHPS. HCAHPS is a survey that patients take here in the United States post discharge about their experience. And I want to just assure anybody on here that this is not an intent to criticize HCAHPS. It's a recognition that HCAHPS was developed for an important person in the early 2000s that served a wonderful purpose. But time has evolved, and our focus now in healthcare has really focused on safety and bias and discrimination and other diagnostic issues, where HCAHPS has evolved along with us. So we think this is a great opportunity to take the beauty of HCAHPS and elevate it to including questions that patients and family members and communities really want to answer. Next slide, please. So I want to introduce you. Sue Schrant is now going to take over and walk us through some terminology, because terminology is not that familiar with everybody, I know. And so this is going to help us ground us before we really talk about the project, because we will be using some acronyms and some lingo here. So Sue's, thanks for joining, and you can
great.
Take
Thanks
off.
so much. Thanks so much, Sue, and good morning or afternoon, everyone. As Sue said, I'm one of the Patients for Patient Safety U.S. champions, and I've been working with Sue and several of the other PFPS U.S. co-founders on just kind of fleshing. Sorry, I have a dog who is having a nightmare next to me. I don't know if you can hear him barking in his sleep, so I'm going to try to wake him up. So we've been kind of fleshing out this idea of Project Pivot, and I'm really excited to be with all of you. I'm just going to give a very quick walkthrough of a couple of the main terms and acronyms. This is a whole field unto itself. So there are entire courses on what it means to collect these types of outcomes and measures. We're just going to provide a few so that you really get a sense for the goal of Project Pivot and the pieces and parts that would be a component of what we're building here. So first is patient-reported measures, and these contain valuable information from the patient who has that really unique perspective of an entire trajectory of a healthcare event. We've all heard the phrase, "I wish I could have been a fly on the wall," to hear, to see what happened in that room. Well, in our healthcare, we as patients or our families or caregivers are those flies in the room, and we are there for the entire care episode. And that information that we see or that we hear or that we witness often doesn't get captured through other methods. And so that's why these patient-reported measures are so important. So we can starting with some of our kind of alphabet soup or our word salad. So Sue had already mentioned the HCAHPS, and that's really one of our main areas of focus for this project. This is the Hospital Consumer Assessment of Healthcare Providers and Systems. And so this is a standardized national survey that you receive after discharge from a hospital event. And so this is a publicly reported survey of our patient experiences while we are in the hospital receiving care. Patient-reported experiences, or PREs, these provide the perceptions of patients about their experiences. So you can imagine this would be things like waiting time, the quality of communication, how well was the care coordinated. This is also collected with validated surveys or questionnaires, and you collect PREs through questionnaires or tools called patient-reported experience measures, or PREMs. And kind of tying this all together, the most commonly used PREM is the HCAHPS. Patient-reported outcomes, which is maybe even more familiar to several of you, or PROs. These are reports that really can only come from patients, because these are things like our quality of life, our psychological status, how we feel we are functioning. These are also collected with validated surveys, validated tools called patient-reported outcome measures, or PROMs. So we've got the HCAHPS, PROs, PROMs, PREs, and PREMs. So let's go to the next slide. And then a little bit more, and this is really kind of our goal. This is sort of the horizon for us. Patient-reported experience in safety measures, as you would assume, this is information from the patient's view on safety. So incident prevention, patient-reported incidents, incident management, and also patient-reported experiences of discrimination scale. So this is the experience of the discrimination scale, or EOD, or patient-reported discrimination in medical setting scale. These tools capture information from the patient's views on experiences or perceptions of discrimination. What's really important on this slide is that these are not routinely captured in the US healthcare system, but they are captured in other countries. And so we really want to learn about these tools and think about how we could use them or something similar in our system in the US, because we're certainly missing those critical pieces of information when we are surveying or asking for information from patients. So let's go to the next slide. So what is it that we want to fill? We want to fill this gap. Historically, research and quality improvement initiatives have used these traditional measures like the HCAHPS, and used things like rates of preventable readmissions. They've used process measures. CMS, which, as you know, the Centers for Medicare and Medicaid Services, is the largest payer for healthcare in the US. They actually use the HCAHPS information to assess healthcare system performance, to tie to reimbursement. But the research measurement tools in HCAHPS don't include PREs or PROs that are related to those issues that we just talked about, to safety, to diagnostic quality and excellence, or to experiences of discrimination. And then probably most importantly, and really the sort of the germ for this entire project, is that traditionally, patients themselves have not been meaningfully involved through each phase of developing PROs or PREs, or thinking through what these tools should be. There has been some engagement, but not standardized, not always meaningful, and certainly not diverse patient groups. And so when we think about what's important to measure and capture, we have not had all the right people in the room to have those conversations. And so we really want to be intentional and mindful about what's missing and how are we going to capture this information in a meaningful way. And so I think with that, I'll turn it back to you, Sue, to kind of carry us forward for what this is going to look like.
Great, thanks, Suze. We can go to the next slide. And so, looking at this measurement gap, and what Suze just shared, that traditionally patient-reported outcomes and patient-reported experiences, they're questions that we patients answer, typically are not determined by patients what we want to answer. And in a scoping report that came out, I think it was 2019, out of 189 studies where there were patient-reported experience or patient-reported outcome measures developed, only 10% included patients and communities and families in determining what questions they would be answering. And so, how does Project Pivot propose to fill this gap? Well, it seems quite simple, but we're going to ask the patients, what experience and outcomes matter most to them with relation to patient safety, with diagnostic excellence, and experiences with discrimination. we're also going to take this a little step further. And this is kind of a recent add-on to our thinking at Pivot, that while we bring together all these patient groups and communities and have robust dialogue over the next year and a half, basically, we are going to also ask the question, you know, how do you want to report this? Now, a lot of us get surveys in the mail and we fill out a survey manual. Some of us get it on cell phones. You know, how some might be able to do it via telephone, but are we using the right modalities to learn from patients? And then when do patients want to report their experience or their outcomes? Sometimes it might be bedside, you know, while things are happening, but like in diagnostic accuracy, it might be post-discharge. So we want to gather this information, not only what patients and families and communities want to report, but how and when they want to report that. We think this is a great opportunity to basically learn from the patient community. Next slide. So speaking about community, this is now, if you don't see your name up here and you've already reached out to and expressed interest, I apologize. Our tent is growing and we're excited about the enthusiasm and the outreach to us. And we have proactively reached out to many groups as well, but I just kind of want to share who's under our tent right now so far. And as this project gets more structured and as we, go forward between now and next May, and we develop our structure and advisory groups and committees and that, I hope we're all somewhere, in those buckets. But we started with the patient consumer organizations. We do have 3 priority populations that, we're looking at all patients, but we're taking the opportunity as we work with all patients and families and communities and consumers that we're going to do some special focus areas in 3 groups. One group is the disability, both the physical and intellectual disability organizations. So right now we have United Spinal Association, Disability Rights Oregon. You can read it right here, National Down Syndrome Society. We're also focusing on the safety of mothers at birth. And so we're, Mama's Voices have joined us, and Equity Before Birth. This is a real important topic. CDC just came out with a report 2 days ago about how maternal safety has actually not improved. And then AARP has joined us. So the older adult community who often experiences discrimination and misdiagnoses and patient safety events. That is our 3rd priority area. I've also started here Women, Heart, and Sepsis Alliance there at the bottom, because many, especially in the maternal safety bucket, many of them kind of intersect with heart issues and sepsis pre and post birth. So we see that there's a lot of intersectionality here. So we also have the Greater National Advocates, HIV community, patient family centered care group, Libby Hoy's group, and I think we have others that I may not have listed. We welcome anybody listening that would like to join us, a patient consumer organization. Please raise your hand and let us know. Collaborators, I'm calling them collaborators or liaisons, CMS, HRQ, Office of Inspector General, National Quality Forum. IHI is going to play an important role in that they've agreed to do kind of an experimental arm in this project that I'm going to talk about, in reaching out to healthcare systems to see what matters to healthcare systems. What do they want to learn from us? SIDM, the Society to Improve Diagnosis of Medicine, another important partner that I see you're on here, that we really want to collaborate in this area, especially around diagnoses and the patient community. The Patient Safety Movement Foundation is on board, and I have to give a shout out to Joe Chiani, who was the co-chair for the PCAST report that embedded this call to action nationally for improved HCAPS. And then the Leapfrog group, really have shared that purchasers will be very interested in the results of this effort. And then on the right-hand side, you can see that I've listed as advisors, people have reached out to help from what they've learned. A lot of organizations around the world have been working with what Sue's taught, PREMS and PROMs, or patient-reported experience with patient-reported outcomes. So we're all teachers and learners. And so Susan Edgeman-Levitan from the CAPS Consortium. I'm not going to read all these, but you can see Johns Hopkins, Kathy McDonald, You can just read this list that continues to grow. And, we're getting some global partners engaged, which we're going to really explore. How do we take what we learn here and help other countries maybe do the same type of project in their country, or do our learnings inform them on how they want to go forward? I want to give a shout out to the Organization of Economic Cooperation and Development, that's OECD, because we're going to be using one of their tools that we're going to be talking about. They've been instrumental in driving this concept of patient-reported experience in safety measures. Everybody in here is important. If I'm not calling out your name specifically, it's not because of you're not important, it's just for a matter of time, but we're delighted at the level of enthusiasm. And this is, by showing this slide, this is a real invitation to those of you and others who are interested in joining us. And, the saying goes, it takes a village. Well, we are going to need all expertise on deck to make this a success. You can go to the next slide, please. So this is what Pivot is really all about. And I'm going to kind of walk through the steps that we're envisioning. Of course, this may change, but in May of 2024, we want to, by then, form an advisory committee, or maybe committees, we're unsure, to really identify what's already out there in terms of patient-reported experience measures and patient-reported outcomes in safety, diagnostic excellence, and discrimination. I also have a dog here who's speaking to me. And we're going to host an inaugural kickoff, most likely in Washington, D.C., where we can bring people together, really kick this off with the motivation and the enthusiasm and all the partners we need to make this successful. And then we're going to collect, so we're going to first develop buckets of already validated tools. And this is something that will help expedite implementation. If it's already validated, we don't need any more science behind the tools. And so the next step will be to collect input from diverse patient organizations, patient advocacy groups, patient networks, as well as healthcare systems. This is the role that IHI is going to take, as well as maybe other healthcare systems that are joining Project Pivot to prioritize these validated tools. And so we're going to start out. We know some of the validated tools already. So the OECD's Patient-Reported Experience and Safety Survey, and Sue's also mentioned the discrimination in medical setting scale. So we're going to reach out to the patient community via a variety of, we hope, very innovative engagement methodologies that might use social media, that could use maybe a crowdsourcing platform. We've even toyed with using TikTok and maybe capturing themes through TikTok using AI. So we're really trying to think creatively to get younger voices to respond to some of our questions. And so we want to look at the current list and narrow them down to like what matters most to the patient community. And then we're also going to ask the patient community, what's missing from the validated tools? What questions do you want to answer on HCAHPS and on outcomes for research that simply don't exist for further scientific validation and implementation? Then we're gonna, after a period of time, that time frame might take maybe 4 months to collect all of this information. We will analyze this information, and then we'll host a series of small group planning discussions around certain themes. And then finally, in a year after our start date, we'll have a final convening and with the patient groups, patients, other invested groups. And we're going to finalize our list of the existing PREs and PROs for potential. Since they're already validated, they are close to being integrated into current tools. There might be some few other scientific steps that might take place, but we're trying to expedite change. So these validated tools would be like the first to maybe get implemented. Not only in HCAHPS, but patient-centered outcomes research could also utilize maybe subsets of these groupings that we're creating. And then we will also create a list of new patient-reported experience and patient-reported outcomes for future development validation. So we plan to spoon feed these to these measure developers who this is like the very beginning point for them, with whom we hope to work. We will also be, collecting information on what I mentioned earlier, like how do patients want to communicate their outcomes and experience, and when do they want to communicate that? While they're receiving care in the hospital or post-discharge, both. And I do want to say that Project Pivot right now, our first step out of the gates, and maybe this is Pivot 1, maybe there's going to be a Pivot 2 and 3. This is focusing on inpatient care in the hospital, simply because it's what the call to action is here in the United States by our president. And so we think this is the first, our first step into this world. Next slide. So I kind of listed the outputs. The outputs will be these 3 lists that we're going to create. Lists of, the prioritized list of validated tools, of tools that haven't yet been developed, and then what we'll learn from our healthcare systems. What matters to the healthcare systems. And I think this will be an interesting experiment. We're going to collect, what do patients and families and communities want to report to those responsible for improving healthcare, and then flip that around, and we're going to hear, what do those healthcare systems want to learn from us to improve safety, reduce discrimination, and improve diagnostic excellence. And then we're going to look at all of this information that comes together, integrate it all, and say, is there synergy? Are there cross sections between what healthcare systems want from us and what we want to give them? It'll be really fascinating. We will assure that what we generate, however, is going to be outcomes that matter to patients and families and communities. And then on the right hand side here, you can see, what are we going to do with this? This is the had a great meeting with a healthcare leader who just really encouraged us to think about how this won't sit on a shelf somewhere. And so we really want to start by thinking, how do we disseminate and implement? We want to start that action now. We've got all the players as part of the team already, part of our village. And so once we get this information, we're going to disseminate to patient advocacy groups, publishers. We will probably publish an article. We want to get it into researchers and quality improvement, the triple aim, measure developers, NQF, IHI, Patel, CMS, purchasers, health systems and clinician groups, payers. We want to inform Congress about this, and WHO. Can we go to the next slide, please? So why are we doing this? What is the value proposition? What is the so what of this project? So we feel that Project Pivot can contribute to safer care, improved diagnosis, and equity by providing information to HCAHPS. Now, we do have Susan Edgman-Leventan, who is the liaison with the CAHPS consortium. They create the HCAHPS tools, and other measure developers to integrate the questions that we're proposing into their measures, and also, asking them to consider different modalities and different timing of collection of information from us. These are really the issues that matter to patients. If CMS does, if HCAHPS, when it gets redesigned, then CMS can align hospital reimbursement, align that to the patient perceptions of safety, discrimination, and diagnostic excellence. CMS can provide public information about this to patients, families, communities, and purchasers, so that we can compare hospitals, so we can choose which hospital we want to get our care. It'll inform patient-centered research, such as PCORI, HRQ, and others, and quality improvement initiatives, so that their research in QI is more patient-centered. And we also will promote policies to make health systems safer, more equitable, especially around focus area, the 3 priority populations, and those populations who are most marginalized. So that is Project Pivot. That is where we are right now. I hope I don't know if you're providing feedback or questions. I think the next slide is to start the discussion period of time. And I think Marty Hatley is going to lead this session.
Good morning, everybody. And thanks, Sue and Suze, for the nice presentation. We've had a lot of positive comments in the discussion, not too many questions. A lot of suggestions about other groups we should reach out to, and I've captured those. Although, Armando, we do need to copy the chat, just in case I missed something. And then we've also had some additional resources shared. too, articles that are relevant, tools that are relevant. So that's great. So this is our time for discussion, and you see the questions here. I'll keep monitoring the chat, but if people want to come off mute and just address what are the challenges you see in achieving the goals and how do we overcome them? So
Something that I'll, to start the juices flowing, something that I'll say that in reading about past projects similar to this, where they identify why haven't PREs, PREMs, and PROMs been more integrated here in the United States and globally. And there are some papers on this, that there is some cultural considerations, and that this might be elevating. There might be some pushback because we're elevating some tough issues in patient safety. This is a tough topic to talk about when we talk about misdiagnoses or discrimination or patient safety. And we hope we can step into this tough dialogue in a really meaningful way to ensure that this does get implemented, that our system does learn from us. So that is one issue that there might be pushback, because culture, this is a tough topic to talk about.
Yep. So we've got a suggestion from Michael Millinson, who you won't be surprised is very active in the chat, that we reach out to employer groups too, as partners on this work, given their interest in keeping their employees safe and and functioning at work. So
I love that, and I think our with having Leapfrog as a partner, we have kind of a direct dial into a lot of large employers, maybe not all of them, but that's a great reminder, Michael, for us to really remember them as significant partners.
Yep.
There's
go
a
ahead.
couple of hands raised, Marty. I don't, Frederick and Shannon.
Thanks, Suze. I didn't see them. Let's Frederick, how about you first?
Sure. Happy to talk. What we've seen is patients are afraid when they're in the hospital to actually report errors. They fear that their caregivers will abandon them. And quite frankly, anytime a patient claims there's been an error, in the majority of health systems will shut off all dialogue, and they become really ostracized. So this is a major, major problem. The problem, though, if you survey after they get out of the hospital, we find that HCAHPS, about 5% reply. So you're not getting a good survey. And we've been working very hard in our hospital to improve patient satisfaction. It's very, very difficult because the percentage sampling is so low. So I don't know how you get around. If you do it in the hospital, you get everybody, but everybody's fearful. If you do it outside the hospital, no one replies. So this has been a very difficult challenge, I think, for all health systems. And at the University of Florida, we've tried really hard to identify the concerns of our patients, particularly in our hospitalist division. But it's very hard to do.
Thanks, Frederick. Any responses to Frederick? Please go. But while we're waiting, Shannon, you had your hand raised.
Yeah, I was just wondering if there is any sort of a one-pager that we could just share for anybody who may be interested in getting involved in this healthcare systems from this discussion. And then, yes, as far as the statements just made, I think that is a big challenge. When patients are inpatient, they tend to not want to share as much. And when they're outpatient, it tends to be too long and they don't tend to reply. So I agree.
Yep. Okay.
Can I make a response to that? A couple things. We just had a discussion yesterday with the CITM policy committee, and it was a fascinating discussion about the low response rate on HCAHPS. And, something that we amongst ourselves at PFPS US has talked about is that could it be because that the questions that are being asked are not the questions that patients want to answer? And so is there a way to redesign, an HCAHPS a survey or a telephone interview or whatever that's asking the questions that matter most to us. So there might be some kind of disconnect. In terms of being afraid in the hospital, I think that is a reality and something we really need to think about. And we have to think about, what if patients directly reported through an iPad or something that didn't necessarily go to the team caring for them, but it went to a higher authority or a centralized location where they wouldn't be directly communicating with those delivering care. So there's a lot of considerations that I think as we evolve and work with patient groups and healthcare systems, we could talk about how do we reduce that fear and give them confidence. It also talks about the culture of the hospital, because if a patient is fearful of speaking up about safety or discrimination, that speaks to the culture of that organization. So how can that culture of the organization welcome it, encourage it, make the patients feel safe?
Yep. Sue and everyone, we have a very active chat now, and Nicole Cable just made a comment that what they hear when hosting focus groups is a belief that patients don't think their data or their feedback is going to be used.
Right.
That's another concern.
Yeah.
I'm wondering also, just reflecting on Frederick's question and all of the comments to it too, whether the way we ask the questions, sometimes the way they're phrased, betray assumptions that we're making that are stigmatizing in some way, or cause people to think that they're going to be identified or misidentified in some way. I'm really thinking about the stuff we've been seeing recently from the HIV community, when they probe for lifestyle issues. So
Right.
Lots more resources that are coming into the chat box as well.
Great.
Sue and Suze, I've got a question for you. We're focused on HCAHPS, but there are CAHPS survey tools for other care settings too. Do you think the research we're going to be doing is going to be useful in outpatient care and long-term care and in those settings?
I think longer term, I think maybe if we start with the HCAHPS and learn from that work. I don't know why it might not look the same. It won't look the same, but focusing on these issues is important regardless of the setting of care. I think, yeah.
Yeah, and I agree, Marty. That's, I kind of alluded to maybe a pivot 1, pivot 2, pivot 3, and that we're focusing right now just in the hospital to get like our methodology under our board, create our community under pivot. And then we might be able to go into, more ambulatory and then long-term care. I would imagine there's going to be, some similarities in terms of the outcomes and experiences that matter to the patients, but there might, like Sue says, there might be some setting specific questions.
Yeah. It's just, I'm just thinking that, so much care happens outside of hospitals that lead to misdiagnosis or delayed diagnosis. Kim Street made a comment too about whether people are going to would be more comfortable and be more open and honest if questions come at them via a bot versus a human. And that kind of plugs into the exciting stuff that's happening in AI. So thanks, Kim, for that suggestion.
Can I address, somebody mentioned about health literacy, especially in lower middle income countries, which is a challenge, of course. And if we have anybody from lower middle income countries, online, please chime in. There are, it's not necessarily patient, well, it is patient reported experience, but kind of in a indirect way where, like, I'm just thinking like in Nigeria, they're using WhatsApp to, they do have to know how to use a phone and have access to a phone, but they're finding both in Italy and Nigeria, they're using basic digital technology to communicate with patients, get feedback from them, learn from them. And in some cases, the collection of patient-reported experience and outcomes can be verbal. So that might be something, if a person does not have literacy skills or digital access to digital technology that, we may hear that patients want to respond verbally. Pick up a phone and call a hotline,
Yeah, Salvador and others are saying they're using WhatsApp in Brazil.
Yep.
Okay, good. Several comments here that we should be definitely reaching out to the Barrel Institute, which we haven't done yet, I don't think, Sue. And
No, we
Sue,
haven't. Yep. Great.
thank you for those suggestions.
I
What about-
have a question, maybe Marty and Sue and others, from the other perspective, the other side of this equation. When I think about potential barriers, I'm worried about pushback from hospitals or health systems that they don't want to be. And Sue, you kind of alluded to this. This almost expands the net of what you're accountable and responsible for, right? It goes beyond, was the room comfortable and the food
Right.
good and were people kind? It goes into really important issues. And so who do we need at the table to make sure that when it's time to actually start implementing and pushing for uptake, it feels like that's something we need to start thinking about now rather than developing a beautiful tool that then people are too afraid to use. So I'm just curious about thoughts on that.
Yeah, and that's a great, Sue, that's, how we're building this is to bring everybody, like I said earlier, under our tent right now. We have CMS, we have IHI, we've got the National Quality Forum, we've got a lot of people at ground zero with us to help us, think about these potential challenges. But the reality is that, we are, the government is calling on healthcare systems to improve, reduce harm from unsafe care, to improve equity and diagnostic excellence. So I'm hoping that by having people at the very beginning as partners will also drive better or easier implementation. I don't expect this to be easier, but maybe smoother implementation.
Sue, I'll mention another challenge too. We've been fortunate so far in getting this work funded, but the scope of this project, is directly related to how much funding we have for it. So if any people have suggestions for other organizations we should reach out to, we've got a very nice sort of base grant from Gordon and Betty Moore, a new grant from Hartford Foundation, other applications in the works. Again, this is going to be a longer term project, and we're already kind of thinking about its full potential.
Right.
And while I'm pitching, if you want to join project or PFPS US too, if you haven't joined it yet, check out our website, PFPS US, and you can join either as an organization or as an individual. I'm assuming most people here probably know that already, but it never hurts to reinforce through repetition.
Well, Marty, we have a hand up from Fozia Asif.
Yep. Fozia, thank you. Fozia, do you want to come off mute?
Oh, we can't hear you.
Fozia, is that you? We can't hear you.
Yeah, she's on mute.
Yeah, and we can't take her off mute, right, Armando?
I've asked her to.
Yeah. Okay, keep
And
trying.
Marty, I'm just noticing we have 5 minutes left, and we have to talk. We want to cover a couple of webinars that are coming up as well.
Okay, so Fozia, if you can come off mute, please do. Otherwise, let's move along and continue to use the chat. As to make further suggestions or questions. We're going to capture everything in the chat. Thanks, everybody. Okay, I think I'm covering this slide too. So I want to bring to your attention 2 more webinars that we're doing this year, because there has been so much happening in the field of patient safety in the United States. And one of the things that has happened is that CMS has developed with a group of measure developers at Yale a patient safety structural metric. They also call it an attestation metric. And this goes to leadership and culture in organizations. The way these work is that if you're a hospital that's participating in the Medicare program, which almost all hospitals are, there are certain things that CMS will publicly report, and they are going to propose on December 1 of this year a measure whereby hospital CEOs would be asked to attest to whether they're doing certain things in patient safety. And those things go to leadership, culture, transparency, accountability, patient and family engagement, and learning systems. And there's no penalty for answering. It's just a questionnaire, but it will give them better data about what organizations are doing in patient safety. There are several of us here on this phone call who are on the technical expert panel that helped construct this. And it's going to be published on or around December 1st. And we're going to have a couple of opportunities in the next shortly thereafter to publicly comment and give CMS feedback. It's very important that we do that because they literally count the people giving feedback and the organizations giving feedback, and they take that into consideration. It's very important. So the first opportunity is on December 15th. There'll be a listening session CMS is doing, and then there'll be a public reporting comment period probably in late January or February. So we're going to do a webinar on the 6th because it will be published by then. We'll be able to share the content. We'd encourage you all to register for this and then get ready to be advocates for pushing this forward. We expect there could be some opposition to this because some hospitals will not look as good as other hospitals. And then we have another webinar event on the following day. We are just packing these in. And this is one that really is focused on engaging patients and families in developing diagnostic research. I don't know as much about the content of this. I know it's a research project that we're involved in. Carol Hemmelgarn, another one of our co-founders who can't be with us today, is the one organizing this, but it's going to be an update, not unlike the one we're doing today, about an important research effort in this field.
Great, thank you, Marty. And I think we are at almost at the top of the hour. I want to thank everybody for joining us, and thank you for your enthusiasm. Thank you for all of your input. We will, we will scour the chat box for all your comments. Feel free to reach out to our website. On our website, we do have, if you want to get involved in Pivot or as a champion or strategic partner. Also on our website will be the recording of this as well as the slides of this. And I don't think we put, all of our personal, the executive committee, our personal emails are on our website as well if you want to reach out. And we will continue to have informational webinars as this develops and as this evolves. And, again, I said that, this is a work in progress. We are thinking big. Marty, you know this, but one of my favorite quotes is make no little plans for they have no magic to stir men's blood. I should say men's or women's blood. And so, like I said, we're flipping the model. We are starting with the patient community, really what matters most to them, but collaborating with healthcare systems to learn also from them, the opportunities and challenges. And, in flipping the model also, we are receiving funding that I hope is sending a signal to other funders of maybe a new paradigm when it comes to patient safety initiatives that are driven and led and people powered. I would say it's really a people powered initiative. And when I say people, I mean everybody under the tent. So Suze, Armando, Marty, any final thoughts or closing comments?
Just thank you for the suggestions and the resources. So we have a suggestion to develop a one-pager. We should be able to do that. Can people use our slides if they want to inform others in the works about this?
Yeah, and actually there is a kind of a one-pager already on our website, a description of the project. We'll take a look at that after this and see if it needs any kind of refining.
Yeah.
But
Okay.
We will make sure we have a one-pager on our website.
Okay.
Yeah.
Great.
Okay, everybody.
Well, thank you,
Yeah,
everyone.
thank you.
Thank you.
Bye.
Bye.